manifestations and consequences of endometriosis urologically. That means the involvement of the ureters and the bladder, and not only at the time of surgery. Oftentimes it's diagnostic. So I see a lot of women in my practice who come in for what they call chronic UTIs and have been treated for months with antibiotics, when in reality they never had an infection and they had endometriosis, and the people who were taking care of them were sort of maybe intellectually uncurious. Let's put it that way. You know, you don't want to flip over a rock if you don't know what's beneath it and you don't know how to treat it. So a lot of my practice is sort of diagnosing women with endometriosis, some of it very early stage, some of it later stage. It's operating on people who have disease in the bladder and on the ureters. And then it's sort of dealing with the aftermath. I like to call it the aftershock effect of what endometriosis leaves behind in the pelvis with regards to the nerves that govern bladder and bowel function, and sort of optimizing women's urinary and bowel function post-operatively and for years to come.
Right. So we at the Endometriosis Summit, I'll like to point out to everybody, it's we work on people. We're a totally inclusive summit, and Dr. Larish does a lot of that in his office as well. Dr. Vidali, why don't you explain to everyone just who you are and how you're affiliated with the Endometriosis Summit?
Well, some of the people watching this may already know me, and the Endometriosis Summit was born out of a wonderful idea, Sallie's idea, and I sort of, you know, put some of my ideas together, but it's really Sallie's baby from the very big, in its own origin, and Sallie knew that I'm a curious person, that she knows that also I am somebody who works well with people, and she knows that we are not partisan. You know, there's, in the world of endometriosis, there's sometimes people have arguments, counter arguments, and we like to be inclusive. We like to have a very open intellectual and scientific discourse, and we're open not at the level, purely at the level of inclusivity in terms of people's opinions, but also where they work. We're open to people of every walk of life, really, and that's, I think, has been the key, and what makes us, I think, original and I think unique, and that's one of the reasons why I think we're so popular as well. And you probably feel the same way, right, Sallie? You may want to expand on that.
Right, I do. I just want to take a chance, though. Dr. Raccuia, can you introduce yourself? And then we're going to have you answer our first question tonight.
Okay, my name is Joseph Raccuia. I'm a general surgeon, but really my specialty is liver and pancreas, and I operate in everywhere from the diaphragm to, I would like to call it the pee-pee, doing everything from diaphragm resection, liver resection, pancreas, bowel work, and exoneration. I've done a ton of re-exonerations for GYN. And I think one of my introductions to GYN was through GYN oncology. And then a few years ago, Dr. Vidali and I rekindled a friendship, and he introduced me to this world of endometriosis, which is really a cancer without being a cancer. And what we were able to do with over 500 patients now, identify areas of involvement. And surprise, 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 most of the areas that are involved are what I call extragenital. What I mean by that is outside the gonads, because most of the GYN doctors that are trained to deal with pelvic problems. When I say pelvic, it's mostly gonadal. Things that occur, for example, in the ureter, the pelvic rim, the urinary bladder, the small bowel diaphragm. They're not really initially trained to take care of these types of lesions in these locations. And I think we've been able to expand our patient base by being able to take care of basically the whole abdominal cavity, from the diaphragm to the pee-pee, as I call it.
So when we went to name our panel at the town meeting, we came to you. You are going to present research that you've been conducting almost for 2 years now. We're not going to present that research here, but so you have to buy a ticket. Town meeting is on sale. But you chose in GYN, we like to use the term extrapelvic endometriosis. You, for very specific reasons, chose the term extragenital endometriosis as a general surgeon. Can you elaborate on why you chose extragenital endometriosis?
Yeah, I think it goes back to the way that these are classified, according to the GYN doctors, is by depth. And quite frankly, in my opinion, the depth is irrelevant. It's more important the location, because if you're going to excise these tumors, you have to have knowledge and experience in being able to not only lift the peritoneum and the pelvis or the gonads, but periureteral, appendiceal, small bowel, large bowel, diaphragm. And we've seen the lesions in all these locations. And ironically, in a lot of these patients, they're more prevalent than they are in the gonads. So I think, having experience outside of what I'm going to say, the female gonad with this disease is essential in being able to treat these patients effectively with, a definitive surgical therapy.
Right. So what area do you think, and Dr. Larish and Dr. Yeung can answer also, what is the most common area in the body to find extragenital endometriosis?
Well, in our data, the ureter and rectum, the pelvic rim, the bladder, followed by the small bowel, then the appendix, abdominal wall, the peritoneum outside the pelvis, and the diaphragm.
Yeah. So Dr. Yeung and I will just call you the SLEW team. I can't keep repeating your name. So the SLEW team, how often do you see extragenital endometriosis, and what is it like in the setting that you work on to assemble a team?
Well, if I could just add, Dr. Raccuia, is that how you say it?
Yes.
What he said, I think what you said is spot on. But, when I talk to patients, I always say, I think there's some of the most informed patients around. They've read everything about endometriosis. They're very well informed for the most part. But when you talk with them about how it's really kind of silly that endometriosis by definition is the cells which line the uterine cavity and are shed during the period are found outside the uterus and outside the ovaries, implanted somewhere else outside the uterus, usually on the peritoneum, which I call the wallpaper of the pelvis, and that can be anywhere in the pelvis or outside the pelvis. So by definition, it's outside the uterus and ovaries, and yet, for the most part, quote unquote, definitive surgery is considered by most to be take out the uterus and ovaries. And oftentimes those structures are normal. But endo, again, by definition, is outside the uterus and ovaries. So, you oftentimes end up putting a patient into surgical menopause and you've done nothing to the actual disease. And our approach is cut out the bad, leave the good. Cut out the actual disease. Sometimes that means the uterus, if the predominant symptom is pain with periods in somebody who's done fertility, but leave the ovaries. The ovaries are normal. There's no need to put them in surgical menopause. So our approach is really to go after the actual disease. And that point that endo is outside the uterus, I think is critical to understanding our approach.
He also said something very important. So I know that we're actually doing a lot of education for patients, letting them know that, making sure patients understand, not only our patients, but patients out there in the world to understand that the hysterectomy is not the treatment for endo, but I want to go even a little bit further than that. Like, castration is not the treatment for endometriosis. Like, it is preposterous how many patients we see every week with the same song and dance, so being told that they had a little endometrioma and they cut out part of an ovary or they cut out the whole ovary. Like, and it's like, it's beyond me how in 2020 we're still having patients having the same story. Oh, I had a little endometrioma and they cut the whole ovary out. I was like, why? Like, that's abusive, right?
Yeah.
I mean, I wouldn't want to have my gonad removed just for some endometriosis. I mean, I don't think we should do that to patients. So I am a very strong advocate against castration.
Yeah, I mean, I have, I also speak from the advocacy and the patient side of things. I had an ovary removed without consent for a pain completely unrelated to the ovary that turned out 7 years later to like cause a massive complication that had absolutely nothing to do with any genital organ whatsoever. And that's actually how I ended up infertile. We have a ton of bladder questions on our Facebook page. Dr. Larish, can you share with us what are some of the bladder symptoms that somebody may have? But also there are a lot of questions on how is endometriosis of the bladder and the ureters removed?
Sure. Thanks so much for inviting me to this. This is really great. So as I mentioned, a lot of the women that I diagnose come in with a diagnosis from either their PCP or their OBGYN of UTIs, or they've been to urgent care 15 times in the last 3 months. You know, it's outrageous. And then when you actually pull the medical record from any of these places, including hospitals, urgent care centers, primary care doctors, gynecologists, and you look at the urine cultures, they're all sterile. So I would say the number one symptom of urinary endometriosis, or at least I should say endometriosis affecting the urinary system, whether directly or indirectly, and I'll get into that in a second, is a feeling of urgency, frequency. Urgency meaning when you gotta go, and frequency meaning you wanna go all the time. Waking up in the middle of the night more than once is pretty much abnormal. Feeling like you have a small bladder, getting up from your desk at work 15 times when everybody else sort of seems to be sitting there feeling well and not getting up as often. Those are typically the symptoms that people complain of. Things that sort of clue us into more significant involvement of the urinary system with respect to endometriosis. The presence of blood in the urine is a big one. And the blood does not need to be blood that you can see with your naked eye. It's what we call microscopic blood or microscopic hematuria. That's usually a pretty good indicator that there's something bigger going on. The thing that scares me the most, though, is the endometriosis affecting the urinary system that's silent. That's the one that scares me, because that's how people sort of, if you have a immediate and sort of acute blockage of your ureter, you are doubled over in pain and it is horrible, and that's what kidney stone patients look like. The problem is that with endometriosis, that same sort of blockage or obstruction can be slow and insidious, and it can cause what we call silent obstruction or asymptomatic obstruction. And by the time we figure out that there's a real issue, people sometimes lose kidneys. And we've seen many, many patients where the kidney function is 0 on the side that's blocked. And so I view my role as an early diagnostician to identify those patients who are at risk, an early interventionalist to get involved before somebody loses an organ like a kidney, and then dealing with all of the after effects of endometriosis with respect to the urinary system. Unfortunately, endometriosis is one of these diseases that even after it's surgically removed, there are echoes or aftershocks that are left behind with respect to the urinary bladder. And so there has to be somebody who's dedicated to knowing how to deal with the bladder afterwards. That's right, you, Sally. Stop. Who's got 2 thumbs and his name is Sallie Sarrel?
Right.
So,
or as a pelvic therapist. But there, I get that you need intervention beyond that. Yeah.
Whoever it is, I mean, but there's got to be somebody with fingers on the pulse, sort of ready to intervene, because that is oftentimes the most troublesome symptom that women have after surgery is sort of completed. And so that's sort of, go ahead, sorry.
So let me just take a minute. Dr. Larish mentioned something very interesting. He talked about hematuria or blood in the urine or silent blood in the urine when you don't have your period. And I can say at least once a week, somebody comes to me that said, I have blood in my urine, but they don't find any cause for it. I can also say myself at 15, well, I had all this testing. Why do you have blood in your urine? Well, it turned out at 35, I had endometriosis. Dr. Yeung, you've done a lot of studies in teens, or one study in particular in teens. How do you manage, or how do you make sure, or what can we do as a society to make sure earlier diagnosis happens and we hear those symptoms?
Yeah, so I get that question all the time. That's a great question. Like, how much pain is too much? So, you know, if you have to take some ibuprofen, a young woman has to take some ibuprofen or something to get through the first few days of her period, I would say that's pretty normal. That's kind of run of the mill. But red flags for me would be if a patient is missing school or work during the period, is curled up in the fetal position on the floor during the period, has gone to the ER multiple times, and they're told they have a ruptured cyst. Classic, right? Ultrasound is negative. They see some fluid in the pelvis. Everybody has fluid in the pelvis. Must be a ruptured cyst. Or they have to plan their vacations around their period. You know, we have some patients who do that. They have to take narcotics to get through their period. Or now it's CBD to get through their period. Or a big one is they take hormones for the pain, like birth control pills, and do not feel better. Your chance of endo goes up. So those are all red flags.
Can I add one more thing, Sally?
Yeah.
The big one that and I see this oftentimes in my private practice is women who have pain with sex, specifically deep penetration. That's another red flag.
Well, we had a whole Facebook Live on that last week, but that is a huge red flag. I also will say for the New Yorkers that are out there, it's a tip off if it's the teen that schedules, that knows where every bathroom is in the school, because she could either have a stomach ache, we're going to talk about bowel symptoms in just a minute, or they can't hold it. When they have to go, they have to go. So like for a little while, like my people that work, they'll know where every bathroom is between Penn Station and the subway station and the subway station and their job, because that's it. They either have diarrhea and constipation, or they have to pee every 5 to 6 minutes. So
we call that the Starbucks mapping effect.
Right. I know that tomorrow the Endometriosis Summit will run a blog from Maurice Chung, who has talked about bladder and endometriosis pain going together as evil twins. Dr. Raccuia, we have tons of questions on bowel pain, and then we have a lot of diaphragm questions we'll have to get to. But what do you find the bowel symptoms are in somebody who has bowel endometriosis?
I mean, I think they can be everything from very subtle to we've had patients that were almost completely obstructed. And I think here, more importantly, you know, in terms of the symptoms, I think it can be very vague and it can be very pronounced. And it depends upon, I think, the size of the lesions, the effect of the adhesions, which are endometriosis adhesions, and where the lesions are. For example, deeper in the pelvis, you will see larger lesions that will be almost completely obstructing. And I just want to make one comment here from a technical standpoint. In over 500 cases, I think we've taken the whole tube of colon out maybe 2 or 3 times. It's really important that you preserve as much bowel as possible. And what I mean by that is we resect the whole wall that will leave a posterior wall, and then we'll re-anastomose it. We will not do what most general surgeons do, you know, EEA staplers or any staplers for that matter. We do very, very limited resections to preserve as much bowel as possible, because these are young patients going forward. Even with even normal adhesions, we don't like to take down. You know, when I say that, I mean adhesions that are naturally there, for example, ligamentous attachments, because going forward, these patients can then have complications more pronounced from the surgery. So you maybe be doing more to help them in terms of preserving as much of their normal tissue as possible.
So Dr. Vidali, going off of what Dr. Raccuia says, I know you have some strong opinions of bowel shaving versus bowel resection. Maybe you and then our SLU team could talk a little bit about that as well.
I mean, I think obviously it's a clinical decision, and different schools, there are different schools of thought. I think, for example, I was talking to some of the people in those big Italian centers, and they're doing literally hundreds of segmental resections a year. And and some of them in cases where we would be doing a shaving. And I think that when you're doing a segmental resection, like Dr. Raccuia just mentioned, you are, first of all, committing the patient to a much bigger operation with greater incidence of leaks, posterior leaks, and all sorts of problems. And so, in my opinion, you have to be aggressive, but you also have to be aware of the patient population that we're dealing with. And so I think in the end, it's a balance. So my perspective is, yes, I think shaving is always the way to go. And if you have to do an anterior resection, you could do it. And the technique that you're using is independent. So people like to do that EEA, sort of like discoid resection. I mean, we just cut through it and re-anastomose. That's what we do.
Yeah.
I'd like to hear what Dr. Colon says. Yes, go ahead. Go ahead, Joe.
I was going to mention one other thing. These are young patients, and the presumption is that during their lifetime, they might have another surgery for something else. And and this is not a cancer, although it acts like one. The most minimal surgery you can do to remove the pathology, I think, is warranted. And really what it goes to is when you involve, extra, what I say is, non-GYN surgeons and GYN surgeons, a lot of people, they act like that. I have a hammer and that looks like a nail. And this is something that we have to get away from, because these lesions are not cancers. To do a whole, what you call a segmental resection, is quite ridiculous. And I think I can count on my hand how many times we've done segmental resections in hundreds of patients that have bowel involvement. So I don't think that is an option if one, considers the clinical and technical aspects of what you could do with these young people.
But SLU team, what is your opinion, shaving versus resections?
Okay, two things. Number one, I just didn't I wanted to say something before we moved off topic, which was regarding the pediatric patients, which we tend to do a lot. I want patients to understand, because since we see so many pediatric patients, the same thing happens. You have some of these girls that, I know Dr. Yeung said that those patients that miss school or work, but for teenagers, a lot of the times it's a lot harder for them to miss going to school. And so in teenagers, I think it's more indicative of having more disease or more issues in some of those patients that suddenly stop doing the things that they like to do because they have their period. Because a lot of the mothers, even though they have pain, we all know a lot of mothers would tell their patients, it's okay, the women in our family have bad periods, so you can take it if I did. So, which is a horrendous thing to say, but they come from a place of love, trying to push their daughters. But now that endometriosis awareness is a lot more, then they're understanding the errors of their ways. That's the first thing. The second thing, so shaving versus discoid versus segmental resection. So we do a lot of bowel endometriosis in our center. And I have to say that we kind of try to individualize the treatment from patient to patient. One of the first things we do is just speak to them as much as we can about the risk of doing some shaving, or doing a discoid, or doing segmental resection. I think there's not a 100% true or 100% correct answer. Personally, we do a lot of segmental resections, depending on the patient. If this is a patient that is, for example, done having kids and completed childbearing, and they have a totally, a nodule in the bowel that goes all the way to the mucosa, to do a shaving in this patient is not going to do anything, right? So in these patients, we do segmental resections. Or if it's, depending on the size, if it's a small nodule that we can see, we also do a lot of discoid resections, but we do segmental resections in patients that have extensive endometriosis in the bowel. Now, that being said, because we are a referral center for endometriosis, like Dr. Vidali is, he gets the worst of the worst cases of endometriosis. And a lot of the times when they come to see Dr. Vidali or Dr. Sarrel or Dr. Yeung, some of these patients have had 5 or 6 surgeries, have had partial castration, have had sometimes hysterectomies, and they leave a lot of disease in the bowel. One of the things that actually, it's one of the worst things that I see is patients that get treatment somewhere else, and instead of doing just the diagnostic laparoscopy, they would go in and they suction the ovary out just to decrease the pain, but then spread everything and then just leave it like that, to have the patient go and seek some treatment wherever they can, right?
That's the worst. That's, oh, sorry. Please.
Sallie, you had asked about, you know, how we have a team here at SLU. And I think having a team approach is very important, and having options for how to deal with bowel disease is really a strength and an advantage. So in our center, if there is suspected bowel disease in the preoperative workup, and the importance of the preoperative workup, ultrasound, physical exam, they're not to rule out endo, they're to help plan for surgery. The importance of the preoperative workup cannot be overstated. If during that preoperative workup bowel disease is suspected, we will have a bowel surgeon there. And we together will unstick the bowel or open up the cul-de-sac, and then together decide what has to be done to meet the goals, as Dr. Raccuia said, of removing all the disease in the least invasive fashion. So there was a recent study actually that Horace Roman's group did that showed that the rate of recurrence was actually higher in shaving versus some kind of excision, whether it be disc or segmental. And that was funny when I read that, because several times with one of our bowel surgeons, we'll shave it together, and then sometimes that's enough and we agree. Other times I'll think there's a little bit more and we're not sure. So we'll test ourselves. After the initial shaving, we'll cut deeper into the muscularis, into the actual bowel wall, and we'll label it differently, and we'll see if there was disease there or not. And having the bowel surgeon there is very reassuring and comforting. If we put a hole in the bowel, they can repair the bowel. Or we do a disc, and then we say, even after shaving, is there endo in that disc that we removed? So I just think having options, and together as a team with the bowel surgeons deciding together what is the best way to get all the disease out in the least invasive fashion is a real advantage.
So Dr.
I think, let me just say, interject there. I think it was wonderful the way you guys presented it, actually. I think, I really feel that you presented it perfectly, which is, you should be ready to do whatever operation is necessary. And that's the key. Ready to do whatever operation and try to be the least invasive possible. I think that's like the definition of minimally invasive, which is be ready to do the minimal amount of invasiveness, but if you need to be radical, you have to be radical. If you don't have that capability to scale it up, then you're not doing proper endometriosis surgery. Wonderful way you presented, guys. Really great presentation.
It's funny because we have, we teach residents. And in one of the resident roasts, I got the award for being the maximally invasive, minimally invasive surgeon. Meaning we're maximally invasive about getting out the disease, but hopefully in a minimally invasive fashion.
Great way to put it, guys. Really amazing.
Thanks.
So I'm just curious what the impact on fertility is. We talk about extragenital endometriosis, so everybody thinks that fertility is only about the ovaries, the tubes, and the uterus. But from Dr. Raccuia, from Dr. Larish, certainly from Dr. Vidali, what is the impact on fertility of extragenital endometriosis?
Well, let me just, as a reproductive immunologist, I have to say, we know that endometriosis, somehow I'm not lighting up when I'm talking, it's not recognizing it.
You're lit up, don't worry.
All right, okay.
You're lighting it up.
Can you hear me? Can you hear me?
Yes.
Okay.
Perfectly.
So, the thing there is that endometriosis is an inflammatory disease. And the reason why people have many systemic symptoms of endometriosis are because the body is fighting a battle. It's fighting a battle that you don't see it because it's inside, but it's an inflammatory battle, and it uses up a lot of the body's resources. And these inflammatory processes, of course, affect implantation because, and also increase miscarriage, because what endometriosis does is, and this inflammation does, it lowers the threshold, the barrier to an allogenic, to an immune attack to the pregnancy. And I'll be talking about this during the summit, but that's sort of like how it does indirectly. So it's not just adhesions, it's an inflammatory process. And by the way, this is one of the reasons why, and I'm just going to pull Dr. Larish in, is why sometimes you get these inflammatory symptoms at the level of the bladder too. Sometimes patients don't have direct bladder involvement, but they, you know, you don't see lesions on the bladder, but they have some of these inflammatory sort of like associated facts, associated symptoms. You want to sort of expand on that, Yaniv?
Sure thing. I think you said it right. You know, the endometriosis, in addition to being a focal disease where you have focal endometriosis either in the pelvis or in the diaphragm or on the bladder or on the ureter, it's actually a systemic disease. And there are many parallels between endometriosis and prostate cancer, which I may talk about during the pelvic summit. But I think that the question that you are asking, which is, you know, can you have endometriosis that affects the bladder and the bowel without having direct effect of the bladder and the bowel involved by endometriosis? And the answer is absolutely yes. Specifically, you know, if we think about the anatomy in the pelvis, the bladder and the rectum really share the same innervation from the S2, S3, and S4 nerve roots, sciatic nerve roots. And so when you have inflammation deep in the pelvis that's affecting the S2, S3, and S4 nerve roots, you get dysfunction of the end organ that those nerve roots serve. So if you have an inflammatory process in S2, S3, S4, you should expect sciatic pain, pain going down the back of the leg in some people, with or without involving the bladder, where you feel urgency and frequency, which we spoke about. And urgency and frequency you can also feel in the rectum. And I think that endometriosis patients suffer from all three of these things when the inflammation is enough systemically to irritate the S2, S3, and S4 nerve roots.
So, very interesting. It's our dream next year, because now I have to plan Endo Summit 2020 and Endo Summit 2021. But our dream next year is to do a pelvic nerve panel, an entire panel, and bring in all the experts worldwide, especially from Canada and from Switzerland. But it will take some sponsorship, and we don't take pharma sponsorship. So if you know of anyone, let me know. I get a lot of patients with that leg pain in physical therapy. And you're right. The first place I do before I send them back to Dr. Larish or to another urologist is I do a bunch of techniques that will modulate pain at S2, S3, and S4. So it depends on, you know, whether we're doing exercise or we're doing manual work there to the extent that we can. Sometimes it takes a little shove in a better direction. Dr. Raccuia, we have a bunch of questions on diaphragmatic endometriosis. I know you and Andrea have even gone into the lung, and I've seen video of you doing pericardial endometriosis as well. Can you talk a little bit about what some of those symptoms are and what the chops are needed for the surgeries on people with those symptoms?
Well, first of all, some of them are not symptomatic, and the ones that are have, you know, chest pain with menstruation. And I think Dr. Vidali can, you know, enumerate that from another standpoint more deeply. But from a technical standpoint, we've done every single one of these diaphragm resections. And just let me back up a second. It represents about 3% to 4% of these patients that we see, which when you think about it, it's a humongous number. And when you're talking about a GYN disease, a gonadal disease, and 3 to 4% of the population presents with concomitant, not alone, diaphragm disease, you have to be ready to resect the diaphragm. And the diaphragm resection can be anything from what, you know, you alluded to, as shaving, to a full thickness diaphragm resection with reconstruction. And we've had a couple of cases where it involved the pericardial diaphragm. And you have to be ready to be able to resect these. And I think, again, the resection and the amount of diaphragm that we remove is dependent on the depth and, you know, how many lesions or how big the lesions are.
You know what's interesting, Joe? You may want to talk about cases where some of these patients went to we've seen them go to sort of like regular general surgeons, and they end up, they end up having suboptimal surgeries because they don't take it seriously enough. And then they just get stuck into bad situations, or cases in where the pleurocysts are done and basically without excising the disease. You may want to comment on that, Joe.
Well, let me say it like this. I have done in my time well over 500 sarcoma resections, and I always shunned the topic to say sarcoma surgery, but there is a thing called sarcoma surgery because it involves almost every part of the abdominal cavity from diaphragm to the pelvis. Endometriosis is very similar to sarcoma surgery because it involves multiple organs. And what happens is the average general surgeon might see 1 or 2 sarcomas in their whole career. They shouldn't touch those cases. Like endometriosis, this is a subspecialty. This should be handled by people that deal with an endometriosis on a daily basis and are willing to be able to go and do resections that that maybe the average surgeon doesn't have the tools to do, or nor should they. So I think from a technical standpoint, it's really important that you're able to, look at the levels of disease, where it is, and be able to take care of it at the time of surgery. Some of these cases, I will tell you, are not symptomatic. And I don't want to say they're surprises in the operating room, but the first thing that we do when we stick the scope into the patient is while Dr. Vidali is down below, I examine the whole diaphragm and the whole upper abdominal cavity, because there are lesions that we find that are not related to the symptoms. They're not always related in terms of, they might have pelvic symptoms that far outweigh any symptoms that might be masked by having large bowel, small bowel, appendiceal involvement, diaphragm involvement. So it's really important that you do a whole videoscopy of the abdominal cavity to make sure you're not missing something, especially with recurrent disease or patients that haven't been treated properly to begin with.
The other thing that I would like to mention, and then I'm going to pass the word to our friends in St. Louis, is that it's important to use a 30-degree scope, I think, because one thing we notice is that if you're using a straight-on scope, a 0 degree, it's hard to really look behind the liver. I don't know how you guys feel about that. Do you guys want to comment on that?
Yeah, I think you're spot on. We definitely use, even though we excise, our preferred method or preferred tool for excision of endometriosis is the CO2 laser. For diaphragmatic endometriosis, it's the best way to see. It's actually with a 30-degree scope. Unfortunately, I can't tell you that we have a great thoracic center over here. So a lot of the patients we have sometimes to send out. We did get a recent thoracic surgeon, and he's really happy and willing to work and learn about endometriosis. But we're still not like telling a lot of people or anything like that, because we want them to actually do some cases before we can actually, have more patients come in for thoracic endo over here. But the 30-degree scope is needed to look besides the liver and the pericardium and mobilize all that stuff up there.
Yeah, otherwise you can't see, right?
No, you can't. You can't. You're right. You're totally correct.
Dr. Vidali is a robotics guy. You guys straight stick or robotics?
We're straight stick laparoscopy.
Yes.
Straight stick.
But that being said, I think there is a great use for the robot for diaphragmatic endometriosis, and even sometimes connecting the CO2 laser guide wire to the robot. I think that's also a good tool to use for endometriosis and excision of the diaphragm.
So I'm going to interrupt for just a second. They are talking about the Luminesce laser, right?
Yeah.
And Luminesce is the Endometriosis Summit sponsor, and Dr. Vidali and Dr. Gargiulo will do a live surgery on Saturday. If you are not at the Endometriosis Summit workshop, you'll be able to log on and watch the surgery live and see the tool that Dr. Yeung and Dr. Eugenio-Colon are describing exactly. Okay, go back, talk amongst yourselves again.
No, I wanted to ask you guys, Dr. Yeung and Dr. Colon, I wanted to ask you, I'm curious to know, are doctors referring to you within the university, or are they still trying to do the cases on their own? Are they really, are you getting a good referral system within the universities? Are doctors understanding the need for specialized care?
Yes. So again, I've been here about 9 years, Dr. Colon about a couple of years, but from the get-go, we've really tried to set ourselves up as a referral practice where we take care of the endo and then we send the patient back. So when we see a patient, they always get a referral letter after the consult back to the referring doctor. And then after the procedure is done, they get a follow-up letter to complete the circle and complete the loop, where we describe what we did and what we found. The patient gets the operative note and the pathology report. And then we say, follow up with your regular GYN for your ongoing women's health care. So we're not in the business of stealing patients. We don't want to do regular women's health care. We take care of the endo and send it back. And for most generalists, that's win-win for them. They don't want to have to take care of the endo. They just want the patient back. And for us, we take care of the endo and then send them back. So it's a great relationship. I would say at this point, maybe half of our patients are from referral and half of our patients find us online or some other way.
Okay,
Can I ask you a question? Can I ask a question?
Yes.
What percentage of your practice is pain and what percentage is fertility?
So with the way we divide this is like, I try to do a little more pain, and Dr. Yeung usually sees more patients that are interested in fertility. And we like it that way because Dr. Yeung also has a clinic which is specialized to get patients pregnant, which is called NAPRO Clinic. And he uses a lot of different methods to help patients get pregnant the natural way, especially a lot of patients with endometriosis. And I've seen, me being a skeptic initially, I've seen a lot of its success and been really happy with some of the patients that we do surgery. Some patients after surgery, they feel well, but then they want to get pregnant. And I usually give them some time to do it on our own. Obviously, we are in a religious institution, so we can't do IVF for patients or any of the other infertility, and more invasive infertility treatments. So Dr. Yeung usually takes care of these patients that do not want to do those other methods and want to do a more natural way. And I've seen a lot of success, and a lot of my patients are really happy when they go see Dr. Yeung. So in that sense, some of my patients that I just focus on removing the endo and making sure that we decrease adhesions for patients to make sure that the fallopian tubes are okay, that we restore. So we tell our patients that our business is restoring the natural or normal anatomy. So, and after that, then Dr. Yeung kind of takes care of all that other area to increase the possibility of natural pregnancy for some of these patients that either it's cost prohibitive or cannot do for other religious reasons of IVF.
So I have a question, without opening an entire can of worms, and I'd love to hear from all of you on this, but we'll start with the SLU team. What impact has Orilissa coming to market had on the referral? And if you want to throw in there your opinion of Orilissa, you can do that. I know Dr. Vidali had a post about it today, but we'll start with the SLU team. Do you still get generalists saying, hey, we don't want to deal with this endometriosis patient? Or has it been that they see the commercials, the rep comes into their offices, and they're happy to shove a Band-Aid over a patient's pain?
I'm going to plead the fifth on all this stuff because I'm not really.
I'm going to let you start.
I mean, it's hard to say. So listen, personally, I've not prescribed Orilissa before. I think it's a tool to use for specific things. Personally, which I know some of my colleagues are not going to be too happy about me saying this, I think not everybody should be prescribing Orilissa to patients, if at all. But this is a personal opinion. I know that there's a drug like Lupron or other stuff, and they have their very minute, very specific uses, which thank God I've not done it for the past 4 years, given any of those drugs. But I do understand why some people would like to use that. Now, with Orilissa, it's hard for me to say this, but I prefer somebody giving a patient Orilissa than castrating them.
Well, that's a good point.
So it's hard to say, like, and if some doctors are like, you know what, let's go ahead and let's take out your ovaries and let's take out your uterus, and then, because I don't know what else to do, so let's just go ahead and take out everything. So in those cases, I would be very happy to the fact that they get Orilissa or Lupron, and then refer those patients to people that are going to actually treat the disease. But
can I jump in here for a second?
Yeah,
though?
go ahead.
You know, I just take issue with this because Orilissa, you know, and Lupron, and really any of those drugs, you know, I come from the prostate cancer world, right, which has nothing to do with endometriosis.
Sure.
But those drugs, Orilissa and Lupron and Xtandi and Xgeva, all these drugs, they are meant to castrate. That is what they do. So I just want to sort of jump in here and say you're not in favor of surgical castration, right?
No.
But the medication does the same thing, and we need to keep that in mind, because I've had patients, not necessarily endometriosis patients, but I have a lot of prostate cancer patients who we treat for 6 months with Lupron or one of the newer drugs, and they don't necessarily have a bounce back of their normal hormones afterwards. And these are young patients that we're dealing with with respect to endometriosis. And I think we need to keep it in mind. See, in my mind, I think surgical castration is almost, if somebody else surgically castrates somebody, that's almost better than using one of the drugs, because at least then we know what we're dealing with the Luprons and the Orlissas of the world. I'm not sure that the data is still really, really immature. And I don't know that we can say that this is really a safe drug ultimately.
So if viewers want to look at what the rebound to the hormone statistics are like, for anyone out there who's a Nook member, we did have a post. You can do a search. Dr. David Redwine, a pioneer in the endometriosis field, did that for his lecture at AAGL this year. And the entire video of it is in the Nook, and you can look, he posts those statistics. The rebound is not great. I would think that, and I can be wrong, that the rebound of the hormones would be better withdrawing the Orilissa than if you've already taken out the ovary, because surgical menopause sucks. Just for anyone who doesn't remember, I'm also a patient. Dr. Vidali, Dr. Raccuia, what is your, how has the Orilissa impacted your practice, and do you have any opinions? We will do this at the summit, so I just thought we'd give you a little taste of it tonight.
If I can say something, please. I'm not, you know, look, I'm not a gynecologist. However, like any disease, if you're going to offer somebody Advil for pancreas cancer, you got to go to jail. I'm sorry. You know, I have to say this, because you're proposing that something is working, you're replacing a therapy that's tried and true. And again, I bring the sarcoma experience, like sarcoma. There's maybe one drug that's available for patients that have GIST. Other than that, it's a surgical treatment. And to propose or to even opine to patients that we need to inform them that some drug is going to replace the surgical treatment at this point in medical history is preposterous. And I think it's sending people the wrong message.
Dr. Yeung, you had a comment?
Well, I would say, you know, I really trust patients. And like I say, endometriosis patients are really some of the most informed patients that I've ever met. And I would say our approach is to provide the patients with options and let them decide. You know, it's we report, you decide sort of an approach. And I tell patients, there's hormones and there's surgery. Hormones come in two basic forms. So you have medications that induce a chemical pregnancy, and then you have medications that induce a chemical menopause. And patients need to understand that Orilissa is not a new kind of drug. It's not a new class of drug. It's heavily marketed, but it's nothing but oral Lupron. That's all it is, with the same limitations that Lupron had, which is at best, patients feel better. But when they are no longer on the drug, the symptoms often come right back. It does not diagnose the disease. It does not remove the disease. It does not help fertility an hour later. It is debatable as to whether or not it actually prevents progression of the disease. It can have side effects, and it can make the symptoms worse. I mean, those are just the scientific facts. And let the patients decide. And oftentimes when you talk about chemical menopause in a teenager, they understand that it's not going to help their down the road fertility. They understand that they can have very serious mood changes. Like with Lupron, there is still a Lupron Victims Awareness Network online where patients describe their very serious side effects with Lupron, and that Orilissa is just oral Lupron. They make up their own mind. You don't really have to convince them. And they understand that this is not getting at the heart of the disease and not removing it, and that the only way to do that is surgical.
And I just want to understand that I'm not saying that we should give patients Orilissa or not. I'm just saying that, and personally, I would prefer to see a referral patient that is actually has used Orilissa than to see a referral patient that's been surgically castrated.
Well,
So
I can tell you this from
different.
an unscientific observation in our experience with hundreds of these patients. We've had handfuls and handfuls of patients that were on these medications, and they were some of the worst cases we saw. And the reason I think, as a non-gynecologist, is because, yes, the symptoms might be abated to a certain extent, but the disease still grows. And those patients end up with the worst problems surgically that we encounter. So I think it's a real, it's misguided, and excuse me for saying so, to even include this in the therapy, because, you know, there might be, you know, a small percentage of patient that we can, you know, say, okay, this might be good for you, but overall it's not good.
Right,
My
so
impression, my impression is that the disease behaves a little bit differently. When I see patients that were primarily treated with Orilissa or Lupron, for example, I don't know, you guys may agree, it's the planes are just messed up. You can't peel off an endometrioma; it just gets ingrained deeper.
Yes.
You just end up tearing the ovary to shreds when they've been on Lupron. That's you may agree. I don't know. It's certainly something I observe, and I'm making a video actually to show this. And it's true. I mean, at least I know it to be true, because
I was just about to say, from a pelvic PT standpoint, the connective tissue on somebody who's been on the Lupron is like mush. And so even to make progress on maybe another cause of their pain, which would be their pelvic floor, it's very, very hard, because what should be there sort of, it doesn't feel right, and it's hard to make progress. It's almost exactly what you were saying, but you were saying it from a surgical perspective.
It's hard to peel off those planes, you know, like, because even with the most severe endometriosis, if you're the first surgeon there, you find your way, you know what I'm saying? You know, I don't know if don't you guys feel that way?
Yeah.
Well, I mean, even to say that it's Band-Aid therapy at best, it even sounds too nice. I mean, really, these are medications that induce chemical menopause in young patients. It is, as Dr. Raccuia says, or Dr. Larish, sorry, chemical castration. That's what it is. I mean, that is really the most real way to describe what is happening. And if you understand it that way, you know, to put a young woman, a teenager who's trying to be active and have relationships or whatever, in chemical menopause at a young age, I mean, that makes no sense. You know, we have to do better for patients.
Especially teenagers, wow.
And especially the fact that there are no long-term data on these medications, on the effects of what happens to teenagers. Or I'd love to see a really long study for any patient between 12 to 18 that took Lupron, and then compare them to any women in the general population to see. So that is something that's going to be phenomenal.
I don't think we have data on that yet, and I think that data is going to be hard to get. But I will tell you, from the prostate cancer world, men who are subject to Lupron, even for 6 months, all show a decrease in their bone density, which, if you think about it, you're dealing with somebody, you know, who's a male who has muscle mass. All of a sudden they have osteoporosis. To think that that's not going to happen in young women is absurd. I think that's exactly what's going to happen. And more importantly, and I think this point cannot be stressed enough, For some of these women, this chemical castration that's supposed to be temporary will not be. It will be everlasting and forever.
Right.
Yeah, and that's the data that Dr. Redwine presented.
Right, Dr. Redwine. Well, so our other dream, we'll put this out to the universe, is that Dr. Redwine will join us next year for 2021 and present this research again. But if you look at that video, he shows exactly how many do not go back to a baseline of hormones.
And that shouldn't,
right.
That shouldn't surprise anybody. That's the data in men with prostate cancer. There is no difference. It's the same drug.
What a great analogy. Yeah.
Actually, yeah.
I believe his title is Leuprolide, the D is silent.
Oh.
So he didn't leave anything off the table. And we're going to continue this discussion at the Endometriosis Summit because it's a hot topic. So we're almost out of time. I'm so grateful that all of you joined us. I want to go through, and we'll start with Dr. Larish, and talk about, just tell me a little bit about what you are most excited about at the Endometriosis Summit.
I'm excited about seeing the faces of women who are gaining their autonomy over their health, are self-educating themselves, and becoming empowered. That's what I'm interested in seeing.
Cool. Dr. Vidali, what are you looking forward to the most?
Well, I think I'm looking forward to breaking new ground. I'm looking forward to creating really a forum that is going to be an ongoing forum for the future.
Great.
Thanks to you, Sallie, of course.
Oh, yes, thank you. So I think also Dr. Vidali is looking forward to maybe some of us getting some sponsors. So yes. Dr. Raccuia will head our extragenital endometriosis panel. He will put up his statistics and he will discuss his research, because I believe his dream for the endometriosis population is that we all have multidisciplinary care in the OR. But tell me, Dr. Raccuia, what are you looking forward to at the Endometriosis Summit?
Well, first of all, I got into this whole thing through my good friend here, Dr. Vidali, and I find this whole disease intriguing. And when we started doing these cases and more cases and more cases, we realized, and I'm a statistics guy. I like playing with statistics. I like looking at the facts. So I'm excited to show really how much of this disease is really not gynecological. It's like when you need a urologist to take out a kidney. And it's into the retroperitoneum or involving the pancreas or something like that. You really need a group of people that are interested in specifically taking care of the whole abdomen, so to speak. And I think what I'd like to glean from that is that this is not a gynecologic disease only.
Great. Dr. Eugenio-Colon will be at the Endometriosis Summit. And just to remind everybody, it's a town meeting, so every doctor gets to participate in every panel in the way that they feel fit, but also that the audience gets to participate as well. Dr. Yeung, we hope you will join us one day soon, but tell us each what you could join us online, maybe for the live surgery that Luminesce is going to broadcast. Tell us, our SLU team, what you are looking forward to the most.
The best thing that the thing that I'm looking forward to the most is actually connect with a lot of like-minded individuals that have decided somewhere along their life to make endometriosis their calling, to make the removal of pain, the empowering of women, the elimination of patient frustration their calling. Like, it is the reason I do this is because I saw the impact it had when I was at the CEC with patients. I just look back at all the harm that I personally had done, putting patients on Lupron for years or months and years, and then seeing those patients still not get better. So the fact that I accept that what I did before and how I learned from that and went out and looked for more education on the subject. So that, and I'm very excited to meet Dr. Vidali and other like-minded individuals that treat endometriosis like it's the devil.
Look, you could all, you guys could all just be honest. I mean, we're going to get to meet Nancy Peterson in person, right?
True.
Very exciting. I'm not sure you guys have all met her. Dr. Yeung, I hope you'll join us. What do you feel that you're looking forward to for Endometriosis Summit time?
Well, I'll be there in spirit for sure, and I'll be there online. But, you know, we're focused on the surgery. You know, we got these Nomo Endo Warriors hats on, and we're focused on cutting out the actual disease surgically. But that is just one part of the big picture and of the entire team that it takes to help these patients. I try to make it clear to patients that we treat endo for pain and we treat endo for fertility. But on the pain side, there's so many other factors or things that have to be addressed for best results for the pain outside of surgery for endo. And same with on the fertility side. Treating endo is only a part of it, and there's lots of other factors that can need to be optimized that are non-surgical for best chances for fertility. So it's such a big team that has to be involved to help patients. And as you said in the beginning, the result is, or the end goal is to help patients. And it takes a team. And so to me, the Endometriosis Summit is bringing all these players, all this team together to have these conversations for the betterment of patients. And I think that's a great approach without pharma.
Right. So not only do we have urologists and general surgeons and deal with the multidisciplinary side of that at the Endometriosis Summit, we have 12 physical therapists on our 2-day faculty. We have the queen of patient-centered care, Wendy Weiner, who is the nurse for the Center for Endometriosis Care. We have a sociologist explaining why we need to be more gender inclusive in endometriosis care. But we also have physiatrists to talk about other sources of pain. We have urogynecologists that are going to be there. We have a sex therapist. We have a sex doctor, an MD that specializes in that. And then, of course, my side project, we definitely will be talking about the role of pelvic hernia against the nerves and pelvic nerve pain. And it's a pretty incredible day on top of doing a live art project, on top of having that togetherness all together. So before we say goodnight, I'm going to point out that Endo Threads has done my t-shirt tonight because I am 1 in 10. And Endo Threads has made our custom t-shirt, and we will do a group photo at lunchtime if you have not bought your t-shirt when you buy your town meeting shirt. We have bit the bullet and expanded our Endo Summit workshop event. At the workshop, you'll get to do sort of a live exploration of endometriosis. Anything from, we will have almost like a spa day of endometriosis, where we will work on changing the narrative for yourself, for the people you practice with, and for everybody around you. And we'll meet you back here next Monday night, where we will host the incredible Dr. Susan Clinton. She is the physical therapist who is the inspiration behind our Change the Narrative theme. And we will explore how having a space to heal in and the language you use affects your own quality of life, daily living, and your ability to move forward. So join us next week to explore changing the narrative. And thank you everybody to our doctors. Tickets are on sale, www.theendometriosissummit.com. And I think we have just about 10 workshop tickets left that I'm going to release to the general public as soon as I get off of Facebook tonight. So if you want to go to the Endo Summit workshop, you better hurry up and log on. Give me about 15 minutes. Take care. That's all we have for tonight, and I'll see you back here next week.
Thanks so much, Sally.
Thanks, everybody. Thank you,
Thanks,
guys.
Sally.
Thanks
See
for
you
all-
soon. Pleasure.
See you soon.
Bye-bye.
Turn this on.